Welcome to our CFN webinar series. Today's topic is web-based video conferencing for rural palliative care consultation in the home. We have two presenters today who I'll introduce shortly, but I want to go over a few items before we start based on CFN events and the webinar housekeeping issues today. So just a reminder during the session, please submit your questions using the question feature, and we'll try to get to all the questions today before we go offline. And we will answer as many questions as time permits, and I'll ask the speakers, if we don't get through them all, if I can send them off to them to answer some of your questions. A survey will pop up after the webinar, and please, if you can, provide feedback. It will help us improve our webinar series. And the webinar slides and the video is available within 1 to 2 days, and you'll see down there where it is on our website. And just a reminder for everybody, in case you haven't registered for the Canadian Frailty conference, which is at the Chelsea Hotel following the geriatrics conference, and it will be starting on the Sunday morning. Also, which I don't have on the slide, is we are going to be launching our CFN interdisciplinary fellowship program in the next few weeks. So please be on the watch for that. And these are the next upcoming webinars that I hope everyone will register for: implementing the Frailty portal in community primary care practice, and improving palliative care in long-term care homes using participatory action research. And we do list all the upcoming webinars on our website. So today's presenters, we are lucky to have two of them today. We have Linda Reed-Paul, who's a clinical associate adjunct professor in the Faculty of Nursing at the University of Calgary. She's a clinical nurse specialist palliative care with the Alberta Health Services Category Zone Rural Palliative Care Consultation team. We also have Charlene Salmon today, and she's a second-year Master's of Science student at the University of Calgary, and she earned her Bachelor of Health Science honors degree with a major in Health and Society and a concentration in Sociology. So I'll turn it now over to Linda to start, and Charlene will take some of the presentation as well.
Thanks for the introduction, Carol. Can you hear me okay here?
Yes, I can.
Okay, and the slides are showing?
Yes, go ahead. Perfect.
Great, thank you. So Charlene and I really do appreciate having this opportunity to share the results of our research study with all of you on the line today. And I understand there were just over 100 people registered, so that's great. So thank you so much for joining us. As Carol mentioned, the title of our project is Web-Based Videoconferencing for Rural Palliative Care Consultation in the Home. So before we begin, we'd like to acknowledge with gratitude the funding that we received for this project from the Canadian Frailty Network. And we'd also like to mention that we had great support for this study from the Palliative End-of-Life Care, the Integrated Home Care, and the information technology portfolios within Alberta Health Services, and also from the University of Calgary, where the Research Trust account was held. So I'm going to begin by describing the background and the context of the study, and Charlene will then provide an overview of study methods, and I'll end off with sharing results, conclusions, and next steps. So this was a one-year study. It took place from February 1st, 2015 to January 31st, 2016. It was conducted in the rural part of the Calgary Zone of Alberta Health Services, or AHS. So this is a map of the Calgary Zone, and the yellowish area, or sorry, a map of Alberta Health Services. The Calgary Zone is here in the yellowish color, and it's enlarged over here on the right. Our Calgary Zone Rural Palliative Consult team was established in 2005. We serve all the areas within the Calgary Zone that are outside Calgary city limits. So this is a widely dispersed population of about 350,000 people. We see patients in all settings of care, so acute care, long-term care, supportive living, home care, but the majority of consults, about 75%, take place in the home. And about 70% of patients that we see are seniors aged 65 or older. So you can see here the distance from Calgary city limits to the edge of the zone is about 100 kilometers in each direction. Our rural palliative program offices are located outside the city, one in Cochrane here in the north and one in Okotoks here in the south. And the maximum travel time to a home visit from each of these offices is about 1.5 to 2 hours each way. So when our urban and rural service areas are depicted this way, you can see it kind of looks a lot like a donut. And because our rural team loves working where we do, we joke that we get to work in the sweet part of the donut and our urban colleagues are stuck working in the hole. So this graph shows the increase in the number of initial consult requests to our team since its inception back in 2005, 2006. And you can see that there's been an increase of 152% in consult requests over that 9-year period. So this is likely a result of increased awareness of our team and what we can offer, but it's also a result of the rapidly growing rural population within the Calgary zone. So over this time frame, from 2006 to 2015, the city of Calgary population increased by 20%, from 1 million to about 1.2, whereas the rural part of the Calgary zone, the population there increased by 75%, from 200,000 to about 350,000. So you can see that population is just exploding and creating a lot more work for our team. So we've had an increase in our consult team staffing over those years, but it really hasn't kept pace with that population growth. So why did our team decide to explore the use of video conferencing to conduct palliative care consults with patients at home? Well, first, we realized it's not always feasible for us to get to patients' homes in a timely fashion due to the time and the distance involved in travel. We also recognize that travel can be impeded by poor weather conditions and can be limited by the increasing number of consult requests, as we saw on the previous slide. While we've always made do with telephone consults when we couldn't travel to patients' homes for in-person visits, we recognize that the lack of opportunity for the patient and the consultant to actually see each other does limit the ability to conduct assessments and to develop interpersonal connections. So the telephone option really isn't ideal. And finally, we acknowledge that travel by the patient and family to our office for an in-person visit or to the nearest facility for a telehealth visit in one of the telehealth rooms was not feasible for them due to poor health, limited finances, and few transportation options. There's not the option of transit or even wheelchair accessible taxi or handy bus in many of the rural communities we serve. So given these constraints to in-person visits and the limitations to telephone visits, we decided that in-home video conferencing is an option we need to explore. So this slide just lists the members of our research project team. In terms of budget, we received a $20,000 grant from CFN to conduct our study. And we were also very fortunate to have significant in-kind support from the AHS Clinical Telehealth and Unified Communications and Telehealth Technology teams, both for equipment and for training and technical support throughout the project. So the purpose of our study was to trial and evaluate the use of mobile web-based video conferencing to connect frail elderly patients with life-limiting illness to a distant palliative care physician from the comfort of their rural homes. So I'll now turn it over to Charlene to tell you about the study methods.
Thank you, Linda. So our web-based video conferencing visit was set up where a clinical nurse specialist from the Rural Palliative Care Consult team enters the patient's home and conducts a visit with the patient, family, and home care nurse. The clinical nurse specialist brings their Alberta Health Services provided laptop computer, speakerphone, and webcam to connect with a distant physician. The distant physician is in a private location with their AHS laptop, webcam, and headset. The program Microsoft Lync video conferencing software was used, which automatically encrypts all audio and visual information during the transmission. We used this setup because the healthcare provider presence in the home provided support and could conduct clinical exams, which helped overcome some of the limitations faced by the distant consultant in interactions with the patient and family. Furthermore, this method removes the burden of managing and troubleshooting technology from the patient and family, which can be quite overwhelming, especially when patients are seriously ill, frail, and elderly, and may have losses that impair communication. The technology removed from the home at the end of the visit avoids medicalization of the home, as the device in the home is a constant reminder of their illness. This also avoids challenges associated with loaning and then removing the equipment. This setup also allows for standardization of equipment and software, thereby avoiding issues with incompatible or outdated technologies. And secondary level consultants available to provide support and education to both the primary care provider and the patient and family. This helps ensure that everyone has the same understanding of the current situation and the plan going forward. This slide shows the different equipment that we used in conducting our study along with the associated costs. One thing to note is that the reason we didn't use the computer's built-in camera or microphone was because the external webcam allows for a wider field of view that had a higher image quality, and there was improved audio using the speakerphone. This screenshot is how to initiate a phone call using Microsoft Lync. You just click on the person's name and you can initiate a call. This is a screenshot of what you would see on a distant consultant's computer during a video call. Furthermore, you can do content sharing using Microsoft Lync, where the patients and family can see the content on the distant consultant's computer. And this is a screenshot of a chest x-ray image being shared by the distant consultant. So although this feature of Lync holds great promise for information sharing, we found that it didn't work very well in practice because the extra bandwidth required to share the image significantly compromised the audiovisual quality of the video call. So we wanted to measure these outcomes during our study. We wanted to see if it was feasible, acceptable, effective, whether it was what the quality of the video call would be, impact on access, impact on cost, and resource use. So our experimental design, we conducted a proof of concept descriptive study utilizing mixed methodology. Ethics was obtained through the University of Calgary Conjoint Health Research Ethics Board. We used 3 different types of forms and questionnaires. During the video call visit, the participant data form was filled out. This form captured information about participants, setting, timing, and travel. Post-visits, patient and family members were asked to complete the patient-family questionnaire, where they rated their experience on a 5-point Likert scale and rated audiovisual quality. Patients and families were also provided with a stamped, addressed envelope for returning the completed questionnaires. After the video conferencing visit, the home care nurses and rural palliative care consult team members were asked to complete the healthcare provider questionnaires. These questionnaires mirrored the questions on the patient-family questionnaires. Here you can see the response rates for the questionnaires. As you can see, we are very proud of how high response we got from all the different types of participants. And we conducted semi-structured interviews with the patient and families post video conferencing visits. This took part as either a in-person or over-the-phone interview where we asked questions such as their overall experiences, advantages or disadvantages of using the technology, comparison to an in-person visit, technical issues, comfort, ways to improve video conferencing, etc. Furthermore, healthcare providers took part in focus groups with a facilitator guide and were asked the same questions as the patient and family interviews. All interviews and focus groups were audio taped and transcribed verbatim. This slide shows the different participation rates for the interviews and focus groups of the different types of participants. To be included into our study, eligible patients were identified through the screening of initial and follow-up consult requests as they were received by the Rural Palliative Care Program Office. Patient inclusion criteria included referral, had to be at least 65 years of age, English speaking, and lived within their home. Over the course of the study, only 1 patient who was approached declined to participate. After being identified, we enrolled patients until we reached a convenient sample of 10 video conferencing visits involving both the physician at a distant location, the patient with the CNS in the home, and family members and home care nurses could also participate if they were present during the visit. All participants provided informed consent and were free to withdraw at any time. So we had 10 patients that were enrolled who were mostly 70% female with a mean age of 76.9 years of age. 80% were diagnosed with cancer, had a median PPS of 50%, and there was a complete split in the type of consult. Other participants in our study included 13 family members, which were 8 children, 3 spouses, and 2 siblings, 9 home care nurses, 3 clinical nurse specialists, and 2 physicians. Our complete sample of participants was about 37. For data analysis, we split data analysis into quantitative and qualitative methods. Quantitative data from questionnaires and participant data forms were analyzed using SPSS software to calculate descriptive statistics such as means, proportions, and percentages. Qualitative data from transcribed interviews, focus groups, and open-ended questionnaire items were analyzed using content analysis methods. Research team members independently analyzed the data looking for common ideas or concepts and labeled them with codes. The researchers then developed consensus on codes and overarching themes through an iterative process using in vivo software and multi-phase review and the refinement of the coding scheme. I will now turn it back to Linda to discuss the rest of the results.
Thanks, Charlene. So we'll start with the quantitative findings. This bar graph shows the results from questionnaires that were completed by patients and family members. So the legend is here on the right, and you can see that the vast majority of the responses were agree and strongly agree. That's depicted in the red. The only item with any disagreement ratings was up here at the top, where you see the green bar, where about 10% of respondents did not agree that the technology functioned well throughout the video conference. To highlight a few of the other results, you can see that 95% of respondents agreed they could communicate effectively by video conference, and 95% also said they felt comfortable discussing their concerns. Just over 80% agreed that their needs were addressed by video conference as well as they would have been in person. The results from questionnaires completed by home care nurses and rural consult team members were also very positive, as you can see here. 100% of the healthcare providers felt comfortable discussing concerns of the patient and family by video conference. 96% here felt that the needs of the patient and family were addressed by video conference as well as they would have been in person. And up here, or sorry, that was a little bit less. Up here, 96% felt that the video conference improved clinical decision making beyond reviewing the case with a distant consultant by phone. So there was there was an advantage in having the visual component as well. And as with the patients, patients and family members, about 10% of the healthcare providers disagreed that the technology functioned well. Results regarding savings of time and travel show that palliative care physicians saved an average of 1.5 hours or about 111 kilometers of travel by using the video conference to complete the consult instead of driving to the home visit. Patients and families would have saved the same amount of time, the same amount of travel by not having to drive to the physician's office, and they saved an average of 25 minutes or 22 kilometers of travel by staying home instead of driving to the nearest facility for a telehealth consult from there. Results pertaining to access showed that if patients had not been seen by video conference, they would have waited anywhere from 5 hours to 6 days longer for the palliative physician to be able to see them in person at home. An analysis of the costs associated with the video conference showed that in addition to the cost of the equipment and training that we mentioned earlier, there were also costs associated with the additional staff time that was needed for setting up and troubleshooting the technology at the home visit. This amounted to about 24 minutes of extra time per visit. I'll now move on to the qualitative results. So the content analysis of the qualitative data revealed the 4 themes on this slide, and each theme encompassed several codes. The most prevalent theme was communication, which encompassed the 5 codes listed here. Most participants were very comfortable discussing concerns by video conference, including sensitive topics like prognosis and expected cause of death. It was noted that there might be some topics like delivering bad news or having a really difficult goal of care discussion that would be harder over video conference than it would be in person. Participants found the video conferencing technology didn't interfere with the ability to establish a personal connection, and they described a sense of immediacy with the distant physician. One person I remember said it felt like she was just sitting here in the same room with me. When talking about her video conference visit with the palliative physician, one family member said, "I felt like she was very, very present, and it was much more personal for us. We were more engaged. The communication was actually better via Skype than it would have been if we were all just sitting in the room." Participants noted that the visual connection with the physician prompted an open, honest dialogue, and also found that technical issues could interfere with the flow of conversation. Data revealed there was benefit in including multiple members of the healthcare team as well as family members in the video conference, but there were also comments that including too many family members could hinder open sharing of information. Overall, participants felt that the video conference was better than a phone call, given the advantage of visualization and nonverbal communication, but it still wasn't as good as an in-person visit. For healthcare providers, communication with the palliative physician by video conference resulted in several positive outcomes. These included enhanced continuity of care and more comprehensive and timely discussion, assessment, decision-making, and care plan than would have happened if the palliative care CNS had discussed the case with the palliative physician by phone after the home visit, which is currently our standard practice. So by being able to, for everyone to be able to discuss at the same time was felt to be a real advantage than having to have that conversation post-visit. One of the palliative care CNSs said, "I think it enhanced continuity of care in a seamless fashion because all of the clinicians involved in the care of the patient were hearing firsthand what the patient had to say all at the same time." Communication outcomes for patients and families included enhanced understanding, insight, confidence, and reassurance. The theme of logistics included the 4 codes on this slide. Data revealed that the video conference consult format was less burdensome for patients and families than leaving home to see a specialist, and it was also less burdensome for the palliative care physician than traveling to an in-person visit. Patients were very pleased to be able to stay in the comfort of their own homes and avoid the risks and costs of travel. One patient said, "I'm dying. That's the bottom line. And as a result, I think it gives me a little more freedom than I would have if I had to go in and sit and wait. Plus the fact there's a whole room full of people that are sick. They've got bugs, diseases, what have you. You may not die right away, but you may end up dying because you've picked up a bug from somebody in a waiting room." Patients and families were also pleased about improved access to the physician and decreased wait times. Other logistical comments that weren't so positive pertain to the limitations to clinical assessment over video conference and the fatigue associated with the longer home visits. As one patient noted, "Well, if you really needed her to say feel like a lump or something like that, she wouldn't be able to do it with this technology." Results within the theme of trust were probably the most surprising to our research team. Many patient and family participants did not trust the security of the internet and were worried about the privacy of their health information, despite being reassured that all transmissions were encrypted and nothing was being recorded. One patient stated, "Even though you're assured that it's private and everything else, there's still that, these days everybody's hacking into something, so there's always that little bit of doubt." The other comment that fit within the theme of trust came from one patient in the study. He expressed some uncertainty and distrust about the palliative physician's identity because he wasn't able to see her clearly on the screen and he'd never met her before the video conference visit. The final theme of technical issues included the 2 codes listed here. When conducting the video conferences, there was often difficulty establishing an internet connection, or sometimes the connection was temporarily lost during the session and then we had to reconnect. In addition, the image or audio were periodically lost, sometimes they were unclear or delayed, and this did create some frustration for patients and families. As one patient said, "We kept losing her picture, and you know, it'd be nice if they could make it run all smooth." Technical issues were also frustrating for the healthcare providers involved. One of the palliative care physicians said, "That is very frustrating when you get that weird choppy audio thing or you lose audio altogether for like 2 minutes and then you have to backtrack." So what did we conclude from the results of this study? First, web-based video conferencing for palliative care consultation in the home is a convenient, acceptable, effective, feasible way to provide more timely support to elderly patients and families in rural areas. Second, audiovisual quality is not ideal, but it was adequate to enable communication. Third, video conferencing reduces the burden and expense of travel for patients, families, and consultants, and it increases consultants' efficiency and productivity. Fourth, real-time whole team discussion via video conference enhances communication, assessment, and continuity of care, and facilitates more timely decision-making and care planning. Finally, web-based video conferencing is better than a phone call, but not as good as an in-person visit. We recommend that ideally, web-based video conferencing should be an optional alternate visit format, not a replacement for all in-person visits. We acknowledge this may not be feasible when traveling distances to a home visit are much longer than in our zone, but we also recognize the importance of the touch of the warm hands of the consultant for communicating support to patients and families, establishing an interpersonal connection, and conducting a physical assessment. So where do we go from here? We're presently awaiting the endorsement of Microsoft Lync, now rebranded as Skype for Business, as a clinical telehealth platform within AHS. Skype for Business has been approved for administration and education purposes and for research or QI projects like ours, but it's not yet approved for widespread clinical use. An internal privacy assessment is currently in process. And once this endorsement is formalized, we then plan to incorporate web-based video conferencing as a routine alternate format for conducting our rural palliative care consults on an ongoing basis. We plan to conduct further studies on the use of video conferencing to connect palliative patients at home to different members of their healthcare team, and we also plan to trial peripheral devices to augment clinical assessment from afar. We currently have a phase 2 QI project underway within our zone where a rural home care nurse is in the home with the patient and family, and she's initiating video calls to the distant palliative care nurse or physician consultant, and we're just about to begin trialing a digital stethoscope within this project. Some of the lessons we learned in our first phase project and how we've carried the learnings forward into phase 2 are detailed on this slide. For example, we've streamlined and shortened the video conference visit by creating an agenda ahead of time. We've developed a technical troubleshooting algorithm that can be used to optimize audiovisual quality. We've included more information about internet privacy and security in project materials. And we're also trying to ensure that the distant consultant has good facial lighting and clearly explains their identity and the fact that they're in a private location before we begin the video conference. So thank you very much for your time and attention. That's the end of our presentation. Please feel free to contact me at the email or phone number on the slide for further information and discussion or for future collaboration with our research team. So I'll now turn it back to Carol and Matt to facilitate questions and comments from the audience.
Well, thank you, Linda and Charlene, for an excellent and informative presentation. We do have a few questions. So if you are both willing and ready, I will start going through some of them. The first question is, would you please demo or explain again for us how, it says Lynch, but I'm thinking Lync technology was used?
Okay. Yeah, I wonder if it would help to go back. Are our slides still showing, Carol?
Yes, they are.
Okay. So I think yeah, okay.
I can't remember what slide that was on, but
It's coming up here. Here we go. So if you're familiar with Microsoft Lync, which like I say, the newer version, I think it's 2015, is called Skype for Business. So what we did to make it really simple, like you can connect to people via Lync through your calendar, through Outlook Web Access or whatever calendar you have, Microsoft Outlook. And so when you do that, you have to open up your calendar, you have to click on the link, and you've got a lot more programs that are up and running. So we really streamlined it because it's a point-to-point call. You've only got 2 participants. So to streamline it, we just brought up the, you just bring up your contact list within Lync, you click on the person's name, or sorry, right-click on the person's name, and then all these options come up, and then you just click on Start a Video Call, and the person on the other end will get a little dialog box, and they click Accept, and then you're linked together.
Yeah, that sounds fairly simple.
Mm-hmm. Yeah, it was very, very simple, and like I say, we did find one of the things that we did learn through the course of the project is it was critical that you didn't have any other programs open on either computer besides Microsoft Lync, or it really did interfere with the quality of the signal and the quality of the audio and the visual. So this was a way to not have to open your calendar at all.
That makes so much sense. I know we have that issue sometimes with GoToMeeting and GoToWebinar, that if you have a few things open, it just more havoc, it seems.
Yes.
Okay, so did all the participating homes already have internet access?
No, they didn't. So if they did not have internet in their home, that's when we were able to use the air card within the laptop and connect using a cell signal. So we were able to use that broadband connection, and it relied on cell signal then to be able to conduct the video conference. And in the project that we're doing now with the home care nurses in the home, without the consultant there, all the home care nurses in the Calgary zone have recently been supplied with new AHS laptops and AHS iPhones. And so their laptops actually don't have an air card within them. They're using their cell phones as a hotspot in order to be able to connect to the internet if there's no internet in the patient's home.
Wow, that makes so much sense. So you can never not be without internet. Okay.
Right. Well, unless I should add, unless we are limited by the quality of the cell signal then, and there are some parts in rural Alberta, of course, where the cell signal is not great, and so that is a factor in terms of the quality of the audio and visual during the video conference.
I'm assuming some of the carriers are better in the rural area, and that would be taken into account if this program was to be launched. I know that, certain providers seem to be better in certain areas.
Right. And that is, before we did the phase 2 project that we're starting now, the clinical telehealth facilitator actually had done a bit of a survey of the quality of the internet signal in various parts of the zone. And so we have had a good idea where it would work and where it wouldn't if we were relying on cell signal.
Okay. So you, at this point, you always used your equipment. You never tried out the individual's equipment to see if they could use it as well?
We have not to this point, no. There are some other projects happening in the zone considering the patient using their own computer to connect, but that's fraught with a lot of issues. When we don't use standardized equipment like we did in this study, then it's impossible to ensure that all the peripherals will work optimally and are functioning properly, and it does increase a lot of the variables when providing technical troubleshooting. So it is possible patients or other healthcare providers can download what's called Lync Attendee. It probably has a different name now that it's called Skype for Business, but it's a version of Lync that anyone can download from the internet onto their computer and then connect to the healthcare provider using Lync and it's still encrypted both ways, so it's still very secure. So it is possible for patients to do that and then connect with us via Lync from their own computer. But when they're, they might have a different operating system, their microphone might not work that great, and so there's all those variables where we chose to do it this way so that we had standardized equipment that we knew was current and up to date, and everything would, the programs would speak to each other clearly.
Yeah, okay, and that kind of leads into the next question about confidentiality. You said that whether you have it on your own computer, not that that was a tested option you used, but that it was encrypted, and so how do you ensure confidentiality other than just the encryption reliance?
I guess, well, really that is the ultimate way to ensure that the information is not, well, first of all, it's not recorded. That's one thing that we definitely reassured patients and families that we're not recording anything. So it's just an in-the-moment conversation like it would be over the phone. It just happens that we also have a visual to go along with that. And no one can kind of hack into that transmission as we're speaking, or even if they did, they wouldn't be able to see what was happening because of the encryption. Did you want to add anything to that, Charlene?
Furthermore, we're using the AHS laptop because that's actually another encryption in itself. The AHS laptop is itself encrypted, so we're kind of using a double encryption using Microsoft Lync software and the AHS laptop.
Right, right. And certainly the technical questions, we'd be if anyone has more questions about the technology, we'd be more than happy to connect afterward and put you in touch with our information technology folks that helped us with that side of things.
Okay. Which patients would not be appropriate for web-based video conferencing format for palliative care consultation?
Okay. Well, in the first study, we didn't have any real stringent exclusion criteria. We thought we'd just look at each patient on a case-by-case basis. But what we learned in the first project, and we've carried over to the second, is that we feel the patients that might not be appropriate would be those with significant cognitive impairment issues like delirium or dementia, or significant physical health concerns if they were very hard of hearing, if they had a reduced level of consciousness. Any of those things could interfere with the ability to communicate by video conference, or they could cause the client and family to experience more distress through the video conferencing format. For example, if they were in a delirium or they had dementia and there was a real paranoia component to that, and there was more suspicion about, is this the person who really says they are on the other end of this computer? Who are they really? And those kinds of scenarios might be better in a face-to-face visit. But we did note that even if patients were had significant cognitive impairment or physical health concerns, we could still conduct a video conference with the family if the client was unable or unwilling to take part. And as we know, as people get sicker near the end of life, they may not even be a big part of our palliative care consult visit. It may be more about support for the family at that point.
Yeah, that kind of leads to the next question of what are the clinical benefits of using the video compared to speaking by phone with the nurse present? I know you just said that, people may not want to be part of the video and they would be excluded from here, and so
Right.
the phone would be the next one. So what's your comment on?
About the added advantage? Yeah, when we did our literature review and in our own experience, there is evidence that you can conduct a much more comprehensive, the assessment piece is the first thing, so you can gain a better appreciation for the condition of the patient and the family and the concerns that they have by seeing them. So someone might say, no, I'm not breathless at all. And you actually see them, their picture of them, and you can see they're using accessory muscles to breathe, for example. Or you might notice things like they're more jaundiced, or they just look more fatigued, or so you can pick up those assessment cues with the visual that you may not pick up over just a phone call. And then there is also evidence of that it's easier to establish rapport and an interpersonal connection when you can actually lay eyes on each other as opposed to just being a voice over the phone.
Yeah, that makes sense. Yeah. So here's some other questions that are coming in fast and furiously. Did you have any consults with the caregivers at end of life, and would AHS use this to support caregivers better, especially if they were the only people in the home with the patient at the end of life?
Right. So we did, as Charlene mentioned, there were, of course, there were 13 found. I think of the 10 video conference visits, there was only one where it was the patient themselves, only in the home with the home care nurse and the CNS, but without a family member with them. So every other video conference, there were family members present as well. So certainly there was that component of support for them and provision of information to them as part of the visit. So I think that answers the question. That wasn't in our study, that wasn't like the primary intent wasn't to, we didn't do any video conference visits that didn't include the patient, but they did, the majority, they say, did include the patient and the family, and it was for the purpose of supporting the patient and family as a unit.
Okay. Somebody said, thank you for the presentation. I was just wondering if there's any follow-up to measure health outcomes for those in the study.
Yeah, you know, we tossed that around a lot when we were developing the proposal for the study in terms of whether or not we could measure that and whether we could confidently attribute outcomes to our intervention. And we concluded that it would be really difficult to really definitively prove a correlation or a cause and effect between our conversation or our visit and an outcome following that. So there's just so many variables that we know people's health conditions are changing quickly. They may end up going to emergency the next day, for example, because they had a sudden event like a pulmonary embolus or a bleed, or they just, you know, something happened that changed how they were feeling, and it would have nothing to do with the fact that whether we did or did not have a consult with them, visit with them the day before. So we did include, you know, on our questionnaire, for our patient and family questionnaire, we did say my needs were addressed. I could communicate effectively. You know, we felt like we could ask, and then of course, Charlene in the interviews did ask them questions about that, like, so what did you get out of this visit, and what, you know, and we talked about outcomes that way, but we didn't actually measure outcomes in terms of, for example, whether or not they went to hospital, what their pain intensity was, their symptom scores, and those kinds of things, because like I say, there were just so many variables. The home care nurse was involved, the family physician was involved, other specialists were involved in the care of these patients at home, and we were just one part of that.
Okay. Oh, some more questions coming in. I think you answered that one quite well. There seem to be some issues with the technology used. How can that technology be improved from your standpoint?
Right. Well, in the second phase study so far, we have one of the things we learned, which is really critical, is that if we can avoid using, if we can hardwire connect, so if you can actually take an Ethernet cable and plug it into your laptop and plug it into the wall in the patient's home or in the office, wherever you happen to be, that will improve the quality greatly. And we've done 6 so far in our second phase study, and there was only one brief problem with audio when the nurse in the home had to use her iPhone for a hotspot. Every other visit she was able to plug in right to the patient's router or to the wall, and the physician was in a place where he could plug directly in, and there were no issues with audio visual quality. So that's really an improvement. And I think just those, in terms of our, like I mentioned, we did develop that algorithm for troubleshooting, and so all of that, we've developed kind of a stepwise approach to, if you're having issues, try this first. If that doesn't help things, try this. If that doesn't help, try this. And so the first thing is to be hardwire connected if you can, like I say. But we've also realized that, make sure all the other programs are closed, like I mentioned. And we've also realized that we could, if transmitting video and audio at the same time isn't working, you can mute the audio on Skype and then have the physician call the home and put the phone on speakerphone and do the audio through the phone and do the video through Skype or Lync. And that way then it's only video transmitting and it results in a better quality. The other thing that you can do is, if it's not working well, turn off the video on the consultant end. So then the patient the patient and consultant see each other at the beginning, but then the patient doesn't see the consultant anymore, but the consultant is still able to observe the patient and the family as the visit proceeds. But by turning off the video on one end, again, that really can improve the quality and prevent the freezing of the images and the garbling of the audio and those things that can happen.
Okay. I think this is probably one of the last questions we'll be able to answer today, but a question says, my question concerns the benefit of using a palliative care physician through video conference compared to the efficacy of palliative care CNS in the home. Has this been evaluated? If the point of the video conference is often not medical but related to family support, is a medical visit in person through video conference required?
Right.
That's a big
so I think what they're asking are, in terms of how our consult team functions, that is one of the factors that is considered in terms of triaging our workload. So when we have a consult request that comes in, we'll look at, well, first of all, who's available. Sometimes, whether it's a physician or a CNS, regardless of what the needs are, if there's only a small number of us covering a huge area. So regardless of what the needs are, we do a lot of our roles are very, very interchangeable. So we will, if there's only one person available that day, they're going to do and the visit has to happen that day, they'll do it regardless if the primary concern is support or the primary concern is symptom management. But having said that, if we have the availability of a physician or a CNS, then we will triage according to what the primary needs are. And if the primary needs are family support, then it would be the CNS who would do the visit. And in the pilot study, as we said, mostly because it was really proof of concept, and we were trying to see if the technology worked and how well it worked and how people reacted to it. We did have the CNS in the home because then it was, smaller numbers of people that had to be trained and only certain, fewer numbers of pieces of equipment we needed. So there was the CNS in the home and the physician at a distance, but always with the intent that going forward, that obviously doesn't avoid travel for our team. So it would be the home care nurse in the home, and then whichever consultant is most appropriate or most available would be the one on the other end at the distant computer.
Okay. We have, I think, one last question that we can answer today. There's a few more that have come in, but we probably won't get to them. So the question is, how are physicians reimbursed for the web-based conferencing visits?
Right. So in our zone, in Calgary zone, Our palliative care consultant physicians are paid through an ARP, so that's an alternate reimbursement plan. So they're paid by salary as opposed to fee for service. So it was not an issue in our zone in terms of how they were paid. But I do have some information from our telehealth colleagues, our clinical telehealth colleagues, who are saying that at this point, there is a code for fee for service for a telehealth visit, but the physician must provide the service at a regional health authority telehealth site, health center or nursing station is what the wording is in the governing rules. So at this point, that code for fee for service does not include conducting a telehealth visit with a patient at home. So that is being worked on at the provincial level in terms of having a code to bill for that.
Okay, so I guess that would apply to the rest of Canada too. If this, eventually rolled out, there'd have to be some consistency so that there's uptake on this for sure. Okay. Okay,
Right.
so I think that's it for today. And again, thank you, Linda and Charlene, for presenting and for answering all the questions. And thanks to everyone who attended the webinar today. Hope you will attend the next webinars that you'll see on the screen. And if you could just take a moment to help us improve our webinars, we'd really appreciate it if you could answer that brief survey. And the webinars and the PowerPoint today will be up on our website in the next day or two. So that ends today's webinar, and thanks to everyone for coming on. Have a good day. Bye-bye.
Bye now.